Welcome to Resilience Radio. I'm Irvin Eisenberg, host of the show and owner of Resilience Occupational Therapy. In last episode, we talked with Dr. Jessie Leyse about infectious disease, and I encourage you to check out that episode before listening to this one, as it gives a little bit of context. In this episode, we'll continue the conversation, talking about science and sort of hearing science in real time, with COVID as an example of that, and global health and her experience in Liberia. I find it to be a particularly interesting and thoughtful episode. Enjoy. So I wanted to follow up on some of our conversation regarding science and the mistrust of science in medicine and COVID. And I feel like we had a unique experience with COVID where we were seeing science in real time. And I feel like people think of science as this set of rules that have been decided by the scientists that is then sort of codified, and you either agree with or you don't. And science is a lot messier than that, and people were seeing it in its real-time messiness. And I was curious if you had anything to add to that.
I completely agree. We often think of science as being like in a textbook. This is what was decided as the truth, and so this is what everybody's going to learn. And that's not really how science works. It's called the scientific method for a reason, because it's a constant process of reevaluating the current evidence. And the way we do that in medicine is to continually study and publish studies and re-examine what we're doing, to figure out if it's actually the most appropriate thing to do, or if there's some unintended consequences or unintended harms that we didn't know about. And so, especially with COVID, you're sort of starting from scratch, sort of. I mean, we had the SARS outbreak to base some of this on. But I know people got frustrated when recommendations changed. You don't need to wear a mask. Oh, no, you should wear a mask. Oh, you should wear an N95. And the reason for that, I think, is important for people to understand. The big part of that is that we're continually re-examining the evidence. And so I think a really good example of this is through the entire pandemic for COVID, we would refer to aerosol generating procedures. So things that we do to a patient that aerosolize the virus. So things that were on that list were, having the oxygen in the nasal cannula in the nose, because it's thought that all that air pressure can aerosolize the virus a little more. Putting a patient on a breathing tube, or intubating or extubating, are thought to be aerosol generating procedures. And so through these last 2 years, we have treated those as very high risk, the highest risk that we can do. And so during those procedures, staff needs to have an N95 mask on and goggles, or one of those big called PAPRs where you have the hood over yourself. And just in the last couple of months, there's been evidence that came out that honestly, those procedures aren't that high risk. A cough produces more aerosols, 100 times, 1,000 times more aerosols than intubating a patient does. And so we based our treatment and our protective equipment the last 2 years on what logically made sense, what we assumed was correct based on previous studies and previous information. But then when people went back and actually looked and measured how many aerosols are produced during these different procedures versus speaking loudly and coughing and yelling, those were much more high risk, producing hundreds of times more virus particles in the air than what we thought were these really dangerous high risk procedures. So that's how science works. We do the best we can with the knowledge that we have at that point, knowing that the knowledge may change and we may have to do something different in the future. It's not laid down in stone, and I think that's a difficult thing for people to grasp. A lot of times we want an answer. We want A versus B, right or wrong, and we just don't have that a lot of times in science. We have A for right now, or A in this situation, maybe B. And that's tough. It's tough not to have a solid answer sometimes.
It somehow reminds me of the parallel to the nutrition industry, or the new studies where someone's like, well, now tomatoes are bad for you, as if like the tomato changed, and people's throwing up their arms and being like, well, I can't keep up with what science is telling me today because they'll tell me the opposite tomorrow. And I think there is a like health information fatigue that people have. I was just working with
like
a patient.
Eggs are a big one. Like, you should eat eggs every day, or no, you should definitely not ever eat eggs. But you're right. It's because different studies come out and there's different evidence, and so we base a lot of our decisions on the amount of evidence. So, the more patients you study, the better idea you have of what the actual truth is. So the longer we get into life and our timeline, the more studies we've accumulated and the more information we have. So as COVID goes forward and we collect more data, we'll have differing quote unquote facts that we're following at that time.
I heard a statistic once, and I can't remember where it was brought from, but that most medical health related procedures and practices are based on studies from 17 years ago on average. I think there was some systematic thing that looked at that we're 17 years behind the research, but sometimes it might take 17 years of looking at the different research to know, and then some of it's just the slow moving ship. And
there's so many studies coming out all the time that it's impossible to stay up to date on everything. And I think part of that 17-year lag is trying to get all of that into the mainstream where most of the healthcare workers have heard the information. So all the different, conferences that people go to and journals that are published, there's, I can't even, thousands and thousands of studies published every week on various different things. And there's no way to stay up to date on all of that. So it takes several years for all of that data to become mainstream for tons of people to have heard about and make it a common practice.
Yeah, I can't remember if the stat was 100 or 40,000 low back studies per year. That was like, and like specifically researching low back pain. And like, so how could anyone sift through that? And if you grab a small sampling of that as a consumer who's like, well, I'm going to take charge of my own health, and then you search some interesting procedure or something, you'll find some studies on it that there's no way your doctor knew about it because it may not be legitimate at all. And how do you sort through 40,000 studies?
Yeah, there's a ton of information out there. Having to sift through it are full-time jobs.
Yeah, makes me really respect the systematic medical researchers doing those systematic reviews so that people can actually know what's going on. I feel like we talked a good amount about infectious disease in general, and we didn't get as much into some of the global effects and the either global spreads as well as some of your experiences in like Liberia and some of the other countries you've been to. Are there any particular stories or perspectives you'd like to share regarding your global experience?
I think much of my vision of the world and my outlook on life has been formed in some of those global health trips. I can think of a couple of instances, especially when I was in Liberia. I went during my med-peds residency. So I went for 2 consecutive Februaries. I think I was in my 3rd and 4th years of residency. And we worked at a children's hospital in Liberia. And part of the interest for me in traveling internationally is learning the history of how a country and a people got to where they are today. So Liberia has a fascinating history that's intertwined with the United States. We actually repatriated a bunch of former slaves back to Liberia in the, early 1900s maybe. And as a result of that, which was thought to be a good idea at the time, it set up a whole different social structure in Liberia and hierarchy based on whether or not someone was a former American that came back versus someone who was born in Liberia, and there became this like caste system. And then there was a huge civil war, and the implications and the health results of that civil war, which partially was the result of the US's repatriation of the Liberian ex-slaves. So all of that history coming up over hundreds of years to try to understand how people are interacting with each other, the mistrust of medicine and the government, and trying to figure out the best way to provide healthcare and to provide information in that situation where people don't trust me and they don't trust the government and they don't. So that's part of what I love about global health. The other thing is that most of the time kids don't care about that, so working at a children's hospital, the kids just, I was different. And so it was interesting, and we would chat, and most Liberians speak English as well. And so it was much easier to have a conversation and interact with the kids than it would have been in, a French predominated country or something. And it's just a lot easier to connect with kids, I feel like, but it's also tough when you're in a situation where the kids are sick and it's a resource limited setting. And so if this kid had this illness in the United States, they would, let's say, for example, have a 90% survival rate. But because they were born where they were born, they have zero chance of survival. And trying to come to terms with that and figure out how to provide care in a setting with limited resources when I'm going to fly back to the US in a month where we have unlimited resources. And that crazy dichotomy and unfair situation that is life and humanity. And I got really attached to a couple of little girls in Liberia, and both of them ended up dying, and both of them probably would have survived if they were in the US. And I still have nightmares about them. I still have dreams, and when I think back, I still get really choked up about it. one of the little girls knew she wasn't going to make it. You know, she knew this was going to kill her, and she was 8 years old. And I just seeing that in a kid who wants to be happy and wants to run around and have fun and not have to be in the hospital and not have to think about it. And when we were there, we were trying to figure out, is there a way for us to get her to the US to have surgery? Is there a way for us to get her to South Africa or, you know, Kenya, where there's a little bit more infrastructure and more specialists who may be able to perform this really difficult surgery? And there wasn't any way for us to do that. There had been what's called a brain drain during the Civil War. So many of the physicians and nurses and more educated population had left during the Civil War because they had the means to do so and just hadn't returned yet. And so there was this vacuum of specialists who could treat what she had. And so she would have had to travel to a different country to be treated. And we couldn't logistically get that sorted out. And she ended up passing away. And my husband always says that when I go somewhere, however long I'm gone, it takes at least that long when I get back to process everything that's happened and try to re-enter into my daily life.
What does that, I mean, I can't imagine what that feels like. Of those experiences, how does that re-entry into your medical practice in the States, how does that affect you and what you do?
So Liberia is another good example. The 2 months that I was there, each of the 2 months, I probably saw 30 kids die each of those. So roughly about one child a day. And the cultural differences between how people deal with children's deaths based on how often it happens is so different. And my preconceived notions about how, let's say, how a child's body should be handled, and me getting offended that it wasn't handled that way, when a lot of times people employ different coping mechanisms to deal with the trauma that may seem harsh or heartless to someone from the outside who hasn't had to deal with those traumas every day for their entire life. And so trying to work through that, and then coming back to, at that time I was in Massachusetts and working, in a children's hospital, and trying to maintain compassion and empathy in a situation that in comparison is not a big deal at all. But in this family's world and in their life view and their experiences, it's the biggest deal that they could imagine. And so I think expanding my scope of what it means to be traumatized, or what it means to be stressed or overwhelmed, how different that can be for different people, and trying to really practice empathy and not bringing my own preconceived notions about what's major and what's minor to a situation, but getting those cues from the patient, from the patient's family. Do they feel like this is major or minor? And then meeting them in that situation. it was hard to come back from an 8-year-old dying because they didn't have access to surgery to, a kid having a sprained ankle and being yelled at by the parents or something. It seems like two totally different worlds, but in each of those parents' minds or the children's minds, it's a big deal, and it's a severe, scary situation because they've each had different life experiences up to that point. And I'm still not great at it, obviously, but it's something that I'm continuously working on to try to meet the patient and the family where they are and understand how important or how overwhelming this situation is to them at that point. It's helped me be more compassionate, for sure. But it's also really exhausting to try to do that all the time.
I can't imagine. So you didn't just go to Liberia once and experience this, you came back and then you went again. How was that re-entry to Liberia, where you're experiencing people getting upset about their twisted ankles and then stepping back into a child a day dying?
Yeah. I remember really looking forward to going back to Liberia. And part of it was that I felt like I was, maybe wrongly, I felt like I was doing something more important, saving a child's life versus, making sure a child isn't crying when they're putting an IV in. I felt like that was more important and that I was doing something that would make a difference. Whereas sometimes here, it's easy to sort of feel like, well, if I wasn't here doing this, somebody else would do it. So I'm not necessary. I'm not important to this process. If I wasn't here, someone else would just fill in and do the exact same thing. Whereas when you go to a resource limited setting, you are the resource. If you weren't there, it wouldn't get done. And it helps me to feel more useful and like I'm doing something productive and filling in a need that otherwise wouldn't be filled. So I knew that it was going to be difficult, and I knew that it was going to be emotionally draining. But the flip side to that is that it feels like it's filling a need that otherwise wouldn't, these kids wouldn't have gotten HIV medications or been diagnosed with HIV until it was too late, if we hadn't been there. So we also did a lot of training. So there were some residents and some medical students there in Liberia, and I felt like we were able to provide some more guidance and teaching opportunities to help with their training so that, when we left, it wasn't like we were just creating this vacuum again. We were doing something to help reestablish the medical system and the structure so that the care could continue when we weren't there. And whereas here, I'm training medical students and things, but there's many, many more physicians that are also training medical students. So it was that same sort of filling a need to help bring up the next generation of physicians to fill in those voids.
And this is by no means meant as a guilt trip, but I'm I'm sure it's a feeling that you've had of sort of like, how do you reconcile being here when you feel like there's so much more need for you elsewhere?
It's a huge question. And having had 2 kids now and trying to figure out how to incorporate the global health and filling in that need with needing to be there for my kids and my family. And I haven't figured that out yet. I mean, the last trip I went on was when I was in fellowship, and that was the Ebola outbreak in West Africa. So it's been 6 years or so since I've done any medical work outside the US. And I'm still trying to figure out how to incorporate that into my daily life. I do feel guilty a lot of times. I felt guilty about not going over to the refugee camps in Greece, and not going over to Poland with the Ukrainian crisis happening. There's also, I know a lot of people who do a lot of international work and end up leaving their families for huge chunks of time to do that. And there's some trauma that happens with their family as well. So it's a balance to try to figure out how to support my kids and my family, as well as support what I can in places that don't have access to healthcare. And it's a tricky balance.
And I feel like since I sort of identified that guilty feeling, I would also, in the body of the main interview we did, we were talking about how, like, infectious disease doctors, there aren't many of you, and that's partially due to it not being as funded from an insurance model and such, and I was reflecting on that while you were talking about there being, like, if you weren't there, someone else would be there doing the same job, and maybe not to the same intensity as in Liberia, but I'm not sure that Central Vermont would have an infectious disease doctor who wasn't just that was available to people if you weren't there. People might just have to go to UVM, or UVM would have one less. So everything's a matter of degree and your own ability to sustain your own personal health so you can keep helping. But I felt like that needed to be stated as well.
I think that's part of why I do enjoy being here in Central Vermont rather than being up at a main tertiary care center like UVM or down at Dartmouth. I feel like I'm filling in a hole that would otherwise be there. And because there are a lot of transportation issues for people to get, travel all the way up to Burlington or all the way down to West Lebanon. And I have had a lot of patients say, I'm so glad there's someone here in Central Vermont that I can see for this. So I think that's part of the reason that I love being here and don't mind being the only ID doc and being on call 24/7. It's a need in the community, and I feel like that's what I wanted to do. That's why I went into medicine, right? To help and not be part of a cog of a bigger machine, but to make some sort of a difference. And I feel like I'm more able to do that here than if I were at a big tertiary care center. That's just my own personal belief system and, thoughts coming into this.
Yeah, it's always a tricky when I feel like we can go down the rabbit hole of when someone is in a profession where they're helping others. Well, I could be helping more elsewhere. So, and it's always a tricky balance that everyone needs to strike as to where they are. And no judgment
the difference
meant on my part.
It's also the difference between helping individual patients versus, doing research and potentially helping thousands or 100,000s of patients by this research that you're doing, and what makes the most sense for each individual person and what fulfills their goals in life, I guess. And I struggled a lot with that guilt of not doing research and not doing something higher up the chain, or, maybe I should go into politics instead of medicine because I could change more things. But that it wasn't my personality, and it didn't play to my strengths. And so I would have been a terrible politician. But I think that goes along with what you're saying. Where can you where can you provide the most help, but still succeed and be happy and be fulfilled in life.
Yeah. I think about, I had the opportunity, but it just family logistic wise didn't make sense to do a 2-week, we call them field works, but in most medical things, they're internships or rotations in Dominican Republic. And a lot of my classmates went to the Dominican Republic to be doing pediatric occupational therapy work. And I didn't go partially because of family obligations and it not feeling like the right time, and partially because it felt like a form of tourism that was not that was a self-serving thing. And I'm sure that some of the students got things out of it, but it felt like just sort of a badge of honor for some of these students that they went and they helped out. But I wasn't convinced necessarily, and it's me sort of doing the greatest thing. I was the person who was saying, well, why in the Dominican Republic when you could be in Haiti? Like, that's right there. Like, but it was my personal hesitance beyond the major commitment of doing anything abroad has been how much is self-serving and how much is actually helpful. Not at all trying to say your infectious disease work and pediatric work majorly helpful. Harder for me to be like, well, maybe I showed one kid another way to move their hand a little differently and went to another country to do it and feel really good about myself. Have you seen programs that you question their sort of who it's for, and how would someone who doesn't have the full skills of a medical doctor know that when they're going to another country, it's not just for their self-serving pieces, but that they actually are helping?
Also a very difficult question. There's the whole spectrum. You know, I know that, for example, with my kids, I want to expose them to global health and different cultures and different ways of living, and people were born in different places, and so they live a different way, but not doing that in a way that's just, here, let's take a tour around Haiti so you can see everything. You know, you can see people living in huts. That's not it. You have to try to strike a balance of opening someone's mind and how to do that, but not just, I can't think of another word other than gawking. Not just gawking at people and, you know, touring around, like you said, to see things and make yourself feel better or make yourself feel like you're doing something. One of the things that I found that I think is really helpful is not just going somewhere and doing something and then leaving, but trying to make sure that you're going with a group that is somehow strengthening the infrastructure of the place that you're going. You know, so for example, like I said, when I was in Liberia, we were doing a lot of talks and discussions and small group activities with the medical students, you know, that they may not have gotten otherwise. And so I think trying to make sure that you're not just dropping in, I think it's a good way to put it. You're not just dropping in to do some good and then leaving again back to your comfy house and air conditioning, but you're in some way trying to change that infrastructure so that you're not needed anymore, so that people don't have to drop in and help, but that eventually this place and this community will be self-sufficient. the whole teaching a man to fish rather than giving him a fish. I think that's huge, because people don't want to be dependent on another person or another country for their livelihood or for their success. They want to be able to be self-sufficient and do it themselves. And so I think if you're going somewhere to do some good and try to help, also trying to work in and figure out how to make sure that you're not needed anymore is important, because you don't want to just set up this situation where it's a dependency relationship. That's not helpful. That's a disservice to the place that you're going and the people that you're trying to help. You're just creating this dependency, and the idea would be to create independence so that you're lifting them up to be their own advocates and be able to do their own work rather than having to have you there all the time to help.
I hope you enjoyed that conversation. I know I got a lot out of it. This is Resilience Radio. Thank you to Aaron Marcus for providing us with the music for this show with their tune Some Biological Process. You can check it out in the show notes to have a full description of the credits and where you can download the music and other great music of Aaron's. I hope you've enjoyed listening. Until next time, take care.